And today's topic is linked to a category that is aimed at improving the optimisation of workforce, the productivity of the workforce, the supply of the workforce. What we'll be doing is having 3 speakers. We'll have Sue Henry, who's the Programme Manager for the Innovation Agency's Workforce Programme. We'll then, after 10 minutes, pass to Fiona Lord, who's the Project Manager for the WRaPT Workforce Resource Tool and works at Lancashire Care Foundation Trust. And then we'll have, after another 10 minutes, Mike Seeley, who is the Director for UK Healthcare Solutions at Lantum. And then after that, we'll have questions and answers. So if that's clear, we'll pass over to Sue.
Thanks, Carol, and welcome everybody. I'm delighted to talk to you today about 3 projects which the Innovation Agency has been working on since this time last year, commissioned by Health Education England. These are the 3 projects, and I'll talk in a bit more detail about each of them. Improving career routes for psychology graduates with the intention to improve the supply to the NHS. Designing a place-based workforce planning tool to deliver care to people with mental health and learning disabilities, and taking the place-based approach on a population of around 30 to 50,000. And lastly, looking at how we can make the NHS a more attractive offer for young people. What do we need to do to engage young people to see the NHS as a viable career option of the future? And perhaps not surprisingly for any of you who are on the call, these projects are developed in the context of quite a challenging environment, often referred to as a burning platform or a cliff edge, but the reality for everybody who works in the system. We have an ageing workforce. We don't have a sufficient pipeline of staff for the future. And specifically, we're not attracting people into jobs in the NHS, but particularly around mental health and learning disabilities. And yet the NHS plan very clearly outlines how these areas are going to improve in the future in terms of how we work with our clients in these areas. Our turnover rates are high, our sickness levels are high, and our vacancy levels are high. So that's the backdrop to the projects that we're working on. I think it's probably fair to say that actually these projects have not come about as a result of the NHS 10-year plan. We have been thinking about these issues for quite some time in the Innovation Agency. So if I start with the project that's looking to improve career routes for psychology graduates to improve the supply to the NHS, some of the challenges we face and what we've been told by our higher education institutes is most psychology graduates are interested in a career in the NHS, but most of them are unable to find a suitable job. And we also know that there are no programmed routes for psychology graduates into other areas of mental health, into other careers, into primary care, etc. And one of the challenges put to us by one of our higher education institutions was that they have about 1,200 psychology graduates who would all like to work in the NHS, but the NHS offer isn't good enough for them or is not attractive. So what we're trying to do is, and we've got some research underway, to identify a range of innovative practice that are already in existence. What can we learn from elsewhere? To identify new roles and routes for psychology graduates to secure careers in the NHS. And the research is underway to understand what the barriers are to graduates taking employment in the NHS. And we're undertaking some insight work to find out what exactly graduates are looking for, what sorts of things would make them want to take a career in the NHS, what are the things that we might need to do differently to attract them. One of the big areas for us, and perhaps why the Innovation Agency is involved in workforce projects, is we're really looking to see how technology and how innovation can support our aims. One of our outputs for the future will be to design the future workshop. What does the future look like if we started to think differently about how we use psychology graduates to supply the NHS with greater skills from them? We're due to report on this in July. And perhaps linked to it, but more generally, we have a real problem of recruiting and attracting young people to think about a career in the NHS. So we've commissioned a marketing agency to do some creative and disruptive thinking with us and work with young people and a variety of other people and organisations from outside the system to understand what it is that we need to do differently to attract young people. How can we learn from them? How can we learn from other organisations who have had equal challenges of recruiting people into jobs? So the marketing agency has currently undertaken some insight work for us. So we're doing a desk-based review to see what approaches there are available in other organisations and how other NHS organisations tackling this issue. We know that this is not just an issue for us in the North West Coast, but we also know that we don't attract as many graduates as other areas do. So we'll be doing some quantitative and qualitative engagement with careers advisors, with young people, and also listening and wanting to hear from NHS staff across North West Coast organisations. What is it about the NHS that they like? What is it that they don't like? What prompts them to think about leaving? What could we be doing differently? We're being supported in this thinking by a think tank, and we've invited representatives from universities, youth organisations, businesses, NHS organisations to really try and help us think more disruptively about what we need to achieve to do this. The think tank has met once. We have two further meetings, one in April and one in July. And my ask of you on the call today is if you're aware of any businesses who have got some really innovative ideas about recruitment, I'd welcome your thoughts on that. And finally, we are also looking to develop a workplace planning tool, a place-based planning tool based on localities of around 30 to 50,000 residents. The principle behind this is that whatever tool we develop needs to be able to be replicated and spread across any particular primary care network. We are using the WRaPT tool, which I won't go into any great detail because my colleague Fiona, who's coming on after me, will talk in greater detail about that. We held a workshop yesterday to look at how we could design a future model of care. What would that look like? What are the needs and what are the demands of people with mental health and learning disabilities? And how can we feed that into and shape a workforce for the future? Not taking a roles-based approach, which is our traditional approach to workplace planning and recruitment, but how can we take a skills-based approach to delivering care and a workforce for the future? And more specifically in this is around how we can integrate digital innovation into this to support it and make best use of the human resources. Our workshop yesterday was attended by 60 people from both within and outside of the system. So we are taking a whole systems approach to this, not just NHS, but we had representatives from the third sector, from businesses, to explore what the art of the people might look like in the future. We will be reporting on that in July. All our projects are due to report in July, and if anybody has any further information or that they would like more information or to get involved in any of this, I'd be delighted to hear from you. Thank you.
Okay, thanks very much, Sue. So anybody with any questions for Sue, please put them in your chat box or raise your hand and we'll come back to them. So now we'll pass on to Fiona. So Fiona, I think, is just putting
Hello.
her... Hi, Fiona, over to you.
Hello. Hi. Hello, everybody, and great to be able to talk to you today about the WRaPT tool, which really I want to just touch briefly about what it is, why it's needed, and then also take you through a few elements of the, I suppose, the process, really. Just bear with me, I have a slight technical issue again. Okay. So basically, really about what is WRaPT and why is it needed? Well, WRaPT is actually, it's a service, it's a process, and it's a tool. It started off really about a tool. So WRaPT stands for Workforce Repository and Planning Tool. But really it's evolved in terms of being a tool to model workforce change to actually we are a service and we have a defined process. The service itself is commissioned by Health Education England in the North West, and as Carol mentioned, we're hosted by Lancashire Care Foundation Trust, and we deliver in partnership with GE Healthcare. We have a standard process which takes organisations or systems through a number of defined steps, and I shall talk through those in a moment. And this is around really undertaking workforce planning to address a specific workforce challenge or problem, and really to be able to understand the workforce implications of change and to be able to model those in an online platform. In terms of the tool itself, it's free to use, it's online, and it's a very, very secure system really. It's a modelling tool. It provides a repository to store, review and amend workforce data, and that can be across a number of organisations or systems. It's not just specific to health. We can build in activity data, and it also has a functionality then to model complex multi-layered future state scenarios around workforce change. In terms of why it's needed, so we all know really that there's a need for system transformation, and this is requiring organisations to really look at and understand the impacts on their workforce, things around increasing demand for care, digital and technological advancements, financial squeeze, workforce shortfalls and new and changing career expectations all really need to be part of those considerations about moving services from where they are now to where they need to be in the future. So around our process, we work on a defined process of 5 steps really, which has got subsections within. Starting really, we approach things as a project. So we like to look at a scoping and mobilisation phase. This is really about working with organisations or systems where it's really important to understand what their clinical challenge is or what their problem is in terms of what they're looking to address through workforce. This step really is about, what actually is in scope of the project, what teams are involved, which organisations, where's the geography, what's the patient cohorts, bottoming out things like information governance requirements, making sure that relevant data sharing is in place, taking part in that key stakeholder engagement, ensuring that everybody's on board, everybody's signed up and everybody knows what the expectations of the piece of work is. Moving on then is to a state of understanding what it is that you have now. That's in terms of the workforce that you have that's within your scope, what it is they do in terms of activity delivery, and how much time do they spend doing it. We do this through the collection of data. Now that's workforce data that could be through ESR or other HR systems. By building in activity data, so identifying where activity data may come from. That could be from patient information or it could be from care records, things like that. And also then linking the two together by what we call drivers. That's where we get to a position of understanding how much time as a percentage of a whole time equivalent each role spends delivering the activities that are part of the scope. It's really important at this stage to ensure that the data aligns to the challenge so that what you know is when you're going to be modelling, you're actually modelling what's relevant to the clinical question. Through the process, it may be necessary to undertake a future state development. It could be that actually it's an entire new care model, and Sue touched on some of that with the place-based care mental health project. This is where you can use this kind of data-driven engagement really. So taking your current state, your baseline about what people are doing, where they're doing it and how much of it they're doing. And looking at what's the driver for change. Is it that you're expecting increased demand? Is it that actually because of workforce shortages or workforce shortage of roles, you need to look at a skill mix, for example? Are you introducing new technology? This enables you to really put out there kind of options appraisal about what's the art of the possible in terms of future service state. And that enables you to then move forward to step 4, which is around modelling your workforce against that. This is where you can use the tool to model any number of complex scenarios really, which is about changing workforce, it could be about changing activity, it could be changing the efficiency at which people work, the amount of time that people spend doing the different tasks, etc., introducing new roles, creating new teams that don't necessarily exist currently. And I think the neighbourhood work and some of the locality work is a real good example of how that can be done. And all this can be modelled in the tool. Following on from that, organisations and systems can move to an implementation phase. This may follow, for example, a business case or just generally working through a kind of action planning process. Within my slides, I've actually built in information about each of the different steps. So in terms of, I'm not going to be able to cover them all because of the time, but so for example, defining the challenge, we've got some case studies where organisations may have a specific problem. It might be a recruitment problem. What they look at is actually the clinical question that draws out of that is actually looking at a different way of working or introducing new technology. And this is where, if you go back to our sort of step one phase, where you're looking at what's your clinical question and what may be your solutions to either a new care model or a different workforce solution, and then using the tool to model that through. Just quickly flicking through, I've included some slides here about these screenshots from the tool. As I've explained, it's an online tool. It's free to use, and it's very secure in terms of how users are given access to the tool, which is by organisation, and it's his role specific because of the data that's involved. Each step of the tool, you can get outputs from there, which you can use to build up your scenarios and to build up information you need to maybe as part of the business case. Just going to move forward. Sorry. When we talk about future state modelling, I think where WRaPT really comes into its own is around the complexity of modelling that you can do. You can model activity, which might be moving activity between teams, increasing activity levels, decreasing activity levels. You may want to change your current staff. That might be around just numbers, or it could be actually around skill mix change, introducing new roles, or like I explained, bringing new roles together and different teams together to form, for example, a neighbourhood team. Teams or roles that sit within existing organisations but actually deliver a service within a neighbourhood. You can also model on things like efficiency changes, where you may introduce a new system or technology, and this enables people to be more productive, or for a short period of time they may be less productive, and you can model the impact on the workforce of that. The outputs you get from the tool is showing you by role, by whole time equivalent, and the number you require, and also that the costs are associated with that. I've put at the bottom of my presentation, there's a number of screens from the tool, but also I've put our contact details on our website. On the website, we have a number of case studies about projects that we've undertaken. We also have some information about our capabilities as a team and a service, and also some of the current campaigns that we've undertaken. And that's the end of my presentation. Thank you.
Okay, thank you very much, Fiona. Again, anybody with any questions, we'll come to that, to the questions at the end. So can I now introduce Mike Seeley from Lantum? You there, Mike? Oh, Mike's just loading up his slides, and just to remind everybody, Mike is the Director of UK Solutions at Lantum. Hi, Mike.
Hi.
Bit of background noise, Mike. I don't know if you do anything.
Yeah, apologies about that. Yeah, okay, should be loaded shortly.
That's all right.
Excellent. Okay, well, this is a good opportunity to, in just about 10 minutes, give you a really good quick overview about the Lantum software solution and how this contributes towards optimizing workforce healthcare systems across the NHS. Lantum is primarily an end-to-end workforce solution. It makes it quite easy to manage your staff and pay a lot faster than you've ever done before. And how it does that is that it matches up available local banks and banks of resources according to skills, and it will match that up to vacancies and gaps in your actual roster. So it means that it matches available resources to roster gaps a lot faster. So it optimizes that whole manual process, which normally happens, and bring around and see who's available, etc. We also bring to the table a concept which is pretty unique to Lantum, which is this whole approach of Rocket Pay. And Rocket Pay is a guaranteed next day payment of locum staff when they work and confirmations been received that they've actually worked. That encourages the locums to share a greater affiliation towards becoming part of their local organizational banks, as opposed to necessarily defaulting back to agency, because they know they can get paid a lot faster. And ultimately, that means that Lantum goes even further. We don't only just provide the whole software element of it, but we have dedicated account managers that when there are difficult to fill shifts within organizations, they will physically pick the phone up and try and help fill those shifts for organizations. In terms of Lantum's footprint, Lantum is already very dominant in the primary care sector, working across a number of GP organizations, federations, hubs, etc. And of course, the whole advent of integrated care, which is bringing together clinical pathways under one organization, starting from primary all the way through to secondary, tertiary if required. Lantum stands well poised to optimize that whole process because of the footprint which they already have within the primary care sector. So ultimately, Lantum's already launched 56 collaborative banks, and this is a sharing of local banks across regions, which makes good geographic sense, and also across groupings with a common interest, common direction, etc. There's a presence of Lantum already in 95% of clinical commissioning groups across England. This solution has been built to manage all staff types and grades, and ultimately, if at a local level organizations are unable to find the necessary resources to fill gaps in rosters, we can also provide access to an additional 20,000 clinical resources across the UK. At present, a large proportion of it remains primary, but the secondary element and resources are also growing quite quickly. We are working with the Dorset Integrated Care Solution again as well, which was awarded to Lantum last year. It's going exceptionally well. This is integration of 4 NHS trusts in this region, including Poole, Bournemouth, Dorset Healthcare, Dorset Community, Southwest Ambulance Care, and a number of primary care GP organizations in this region, all under the Dorset umbrella. Along with that, we have a roster solution, which is quite a simple rostering solution, which has already proved to be very beneficial at a primary care perspective for a number of single-site organizations, federations, etc. It allows them to pick those spreadsheets up and turn them into an electronic platform, which everybody can see, giving instant visibility to manage rosters on an ongoing basis. As we've started to work even further with secondary care organizations, we've embarked on expanding this rostering tool to include a number of additional features which are tailored specifically for the secondary care sector. And we'll be adding a number of the junior doctor roles from the recent contract, accommodate consultants, AHPs, etc. So the solution will be for all staff groups. We also provide the whole area in terms of not only having a local bank of workers and workers who are ready and able to work, but we also take care of clinical governance. The system has a ready repository of all the documents which you require for clinicians to work. It certainly has, all the rights to work, etc. is all stored and checked as they're uploaded into our repository, and it's readily available at a local level. Should any organizations have to meet CQC requirements, as and when required, they can easily download all these documents quite quickly. There's automatic notifications, which also tells individuals as well as the organization when these documents are going to expire. So along with that, we provide a number of other tools. We've got diary planning tools, which allows you to manage the availability and timesheets. So not only can we see when a doctor's available to pick up additional shifts at a local level, but a doctor can tailor their availability. So not only will they say, I'm interested in doing additional work, but I can't do work on a Tuesday. I just don't do Wednesdays because of childcare, etc. So it adds towards providing a very flexible workforce. We also have the ability where shift gaps are filled by available and qualified staff. We've got an app which it automatically notifies doctors when there's available additional shifts. It will not just bombard doctors with every shift that's going, but it's tailored according to their skills, their requirements, and their availability. They can, if they're senior doctors, they can book themselves straight in. If they are less senior doctors or less well known by the organization, they can indicate an interest. It comes along with their CVs, and that can be reviewed by the local organization, decide who they'd like to offer that additional shift to. The RocketPay, as I mentioned, has been a significant, I think, significant hit within the actual organization, where doctors are quite welcome the fact that they can get paid next day. It takes away the headaches of chasing all the paperwork, checking if they've been paid, hanging on for weeks on end, which turns off quite a few clinicians in terms of being paid quite quickly. So we take care of that with RocketPay. And this is a reflection on the screen from this particular graph, where we've analyzed that clinicians who are on the RocketPay, they tend to do almost twice as many shifts as doctors who are not on RocketPay. You've also got the ability, again, as well, to tap into additional workforces. As I said, if at a local level you can't find the resources you need, we have got a marketplace, 20,000 plus additional resources, really useful for emergency department and urgent care, where you've got lots of GPs who've got special interests which they want to keep their skills up. It allows them to do that. And of course, when it comes to implementation and rollout, this is all done very quickly. It starts primarily from launch right through customer success, technical support, and right through to payroll if clinicians are on the RocketPay element. So a quick summary of the USPs of Lantum. Quite experienced. They've been around, the organization's been around now for about 7 years. Quite experienced with the whole area of collaborative staff banks. We have RocketPay, which remains very unique to Lantum. We've got dedicated customer support, which helps you to vet clinicians and fill shifts. And there's instant access to 20,000 primary care staff through our marketplace again as well. So of course, as mentioned before, if you've got any questions, we will certainly respond to them via the forum as and when required. Thank you.
Okay, thank you, Mike. So that's the end of our 3 conversations today. So I encourage you all to start putting your questions in. I do have a hands up here from my colleague Sue, who's sat next to me. So we're going to allow her to ask the first question.
Thanks, Carol. So this is probably more directed towards you, but my question is, how do you think we can find clinical supervision for our psychology undergraduates in the NHS when that resource for clinical work-based supervision is already under quite immense pressure, especially with the increased number of AHPs being trained at the moment. What are your thoughts around that?
I think that is one of the big challenges around placements in the NHS as well. It's something we've discussed at our steering group. I think one of the challenges is how you change some of the restrictions around the required number of hours for supervision, and have to think creatively about how we might undertake supervision and who can do it, what levels, what qualifications they need, how long do they need. An example that we've had recently is we've recruited a psychology graduate to do some research for us, and as part of that needs supervision. He's not in a clinical role of any description, he's undertaking some research. But the requirements are that he needs 2 hours of supervision each week, which we've challenged successfully because he's not in a clinical role. But that in itself is a barrier for anybody to take on a placement, and for anybody to take on somebody like Bradley, who's actually not doing any clinical contact and needs supervision, but not in the way that it's set out in the guidelines.
Okay, I think if you have to follow up there, Sue.
Yeah, thanks, Sue. That, it's interesting to hear your thoughts around that. So who do you think we could approach, or which professional groups, perhaps I should say, who could offer that sort of supervision? Thinking of that case example, but also other cases that are going to come through.
I'm not sure about that one at the moment, and I think that's part of one of the exploratory things that we're doing as part of the steering group. But well-trained counsellors who have undertaken a supervision course could be suitable, and I think there probably are other professions that we could look at who, as part of their own training, have to undertake supervision and can be trained to supervise other members of staff in professions, helping professions. I think that's probably what I would say at the moment.
Thanks, Sue. That's really thorough answer. Thank you. I'm with you on all of those.
Okay, so Sue, just a question from me actually. So in terms of the market research generally, the think tank project, do you have any early suggestions, thoughts and ideas coming out of that work, particularly from the youth workers, people who work with our younger people, about the sorts of things we should be paying attention to with a digitally savvy young population?
One of the major things that came out of the first think tank was the NHS recruitment process and the application process in particular. And for many young people, that is a big off-put. So one of the things that's been done in the local youth centre that I live on Wirral, and we've got quite a big new youth centre called the Hive. So they've invited in people from many industries and many businesses and organisations around Wirral to do some interview process and skills to help young people prepare for and experience an interview. As part of that process, one of the stories that the guy who came to the think tank told us, there was two people who, just as part of that kind of process, that mock-up process of an interview, were actually offered opportunities by two of the businesses on Wirral. And when they looked back at what the qualifications were, it was very clear that those two people would never have got a job in the NHS. They probably wouldn't have got through many interview processes because of the way in which they have to apply. So I think one of the first things that we were challenged about was actually NHS jobs and the application process, and also the length of time it takes. So even if you actually get through putting the online application in, you've then got a closing date that's often 3 or 4 weeks in advance. You're then either shortlisted or not, and you've probably got another 2 weeks. So all in all, it could take six weeks to 2 months. what we were hearing is from young people, they've probably lost interest at that point. Is that okay? Hello? Hello?
Type your question in, please. We haven't got any coming in at the moment. If you do want to raise your hand, do raise it and we'll come back to you. But we haven't got anything at the moment, so I'm assuming you've got nothing you want to ask rather than we're missing you. Perhaps Fiona, I could come to you. When your teams come together in the place-based improvement project to imagine what their future model of care looks like in a neighbourhood of 30 to 50,000 residents, how are you bringing together the capability of WRaPT with the knowledge of their clinical knowledge, obviously, but their knowledge of their community and how to build community capacity, but also how do you bring into the project their knowledge of technical and digital solutions that can help them to build a new future?
I would say that the way we work in all our projects is around real good engagement with the people who are delivering the service on the ground. So collecting data is only one part of a WRaPT project. You know, it's really important that data is validated back. In fact, that, you know, the data is actually showing the true picture of reality, and that's in terms of workforce, but also activity, and then having those discussions really about how much time the various different roles spend delivering the activity. But I think also, like what happened yesterday with the mental health project, is that we bring people together to get their input into the development of either the new care model or also some of the scenarios, some of the solutions that we will model going forward in terms of that workforce change. You know, also bringing, I suppose, research from elsewhere in the country and also internationally, any kind of policy sort of stuff that's out there, to bring that full picture together. You know, looking at what other developments have gone on locally. Can we learn from other areas? Is the good stuff already going on? And it's actually about building on and, you know, kind of reinforcing what's good already, not necessarily throwing everything out and starting again. I think that would be my response, and that's not specific to this project. I think that's just the way we work. We really, you know, we really do want to engage with clinicians and the people delivering the service to make sure that it's steeped in reality, really. Does that answer your question?
Yeah, I think, would it be correct to say that you also are inviting innovators into the project, you know, so companies who are in the space of creating integrated care platforms and so on to help them to influence the future?
Definitely. I think it's great to have that two-way discussion and engagement, because obviously, you know, the people from the kind of innovation companies and the technology companies really, I think, would want to listen to what are the frustrations, what are the difficulties, where's the duplications, where's the blocking points, and actually create the solutions in that partnership way, rather than creating something and then take it to market, and it's not necessarily what's required. I think it's a great way to do it.
Thank you. So I'm just going to ask Charlotte, do we have any questions? No, we still don't have any. Come on, we're waiting for you. So Mike, I'm just going to turn to you. You're very good. What are your challenges? How would you feed back to us the challenges that you face when you start to try to introduce your product into a new part of our NHS system? what challenges do we offer to you, and how do you overcome those?
It's a good question. Yes, the challenges are many, especially for an organisation of the size and still in the innovative stage as a Lantum. And a lot of those challenges are around, we normally find that organisations have identified they have a problem. Temporary staff spend specifically remains an enormous challenge across the NHS. Not only is it just expensive, but actually finding people in the first place to fill some of these shifts and to deliver a higher level of patient care is very, very challenging. So that is universally recognized. The issue for an organization like Lantum is that we have found that many organizations are so paralyzed with fear that they make no decisions whatsoever, so it carries on. And secondly, some organizations have found that there is not the same level of support at the exec level to make a change. And it remains an ongoing challenge, and it's very difficult. And that for me presents the single biggest challenge. Biggest challenge for an organization like Lantum is actually organizations doing nothing.
Okay, thanks, Mike. And if you have anybody listening here, obviously we have a mixed audience listening to these conversations, but if we have somebody who's from an NHS system, perhaps from a temporary staffing team, and they're thinking, I'd really like to find out more about this, or have a way of persuading my organisation to look at this more seriously, what can you offer them next?
We're more than happy. We're all over the UK. That's not a problem. We even have an office right in Manchester, again, as well. So we are all over the place. And coming to see an individual organisation, just to show what potential is in the solution, how it works, how we could possibly take it forward, that's quite easy for us to do. That's not a challenge at all. I can be contacted. My contact details, I think, came out, or they can contact me via yourselves. We also are at the stage where we're doing a number of things. If an organisation express an interest in having a look at what Lantum can possibly do, we are more than happy to consider giving free trials for a limited period of time to just use the software, see if it really can deliver a difference. It would fit into what you're doing. In terms of the development of our rostering tool, for example, we certainly have a number of organizations that have started to come forward and say, yes, we would like to look at a simpler way to address the whole area of rostering our medics and eliminating the fact that, I think the major challenge is around the fact that you can't really see what's going on. When changes happen on a roster, it's probably only seen by one or two people. When people are available to work, you don't know. We've got several clinicians who work with Lantum, and one of them, her major gripe is that when there are vacant shifts available, she is a newly qualified consultant. She doesn't even know about them, and she can do some of them.
Okay, no, that's really helpful, and I'm sure anybody interested will pick up your offer there. So if there's no questions, I'm going to end the meeting there. I'm going to say thank you ever so much for everybody dialing in, but also to our three speakers. And to reference that we have a quarterly ecosystem event. The next one is on the 27th of March. Some of you may have already registered. It is fully booked at this time. It has the same topic of workforce optimisation. And to let you know that a document will follow on from this, which is summarising the eco and giving additional information within that. And we will take the opportunity of selling a copy of that to everybody who's registered for this webinar. So thank you very much and have a good rest of the day.